Welcome back to the deep dive. So today we are tackling a mountain of a topic, hepatology.
It really is a mountain.
Yeah, I mean, if you're a med student staring down Davidson's, that chapter, it's just massive. It feels impenetrable sometimes.
Absolutely. And its complexity, it comes from the sheer diversity of the liver's roles. It's doing so much at once.
Right. So our mission today isn't to just, well, read the textbook out loud.
No, that's pointless. The goal is to give you a strategic shortcut through all that density. We're going to build clear, durable memory anchors.
There's aha connections.
Exactly. The essential facts, the clinical rules, so that when you see a patient or you get that exam question, you immediately know which system is failing, how to test for it, and crucially, why it matters.
So durable memory anchors across anatomy, function, the clinical clues, and then the major pathologies, making it stick under pressure.
Precisely. I mean, we're talking about an organ that's, 1.2 to 1.5 kilograms. It has a dual perfusion, massive synthetic capability, and runs about 500 chemical reactions at the same time.
It's incredible.
So we have to understand the blueprint before we can understand its failure. We'll start there. With the foundations, move to clinical clues, hit acute failure, and then finish up with the big categories: viral, metabolic, and autoimmune diseases.
Okay, let's unpack this blueprint then. The source material uses a great anchor to start us off: the city map.
Yeah, a really good way to think about it.
It's because we all learn the basic lobes in first year, right? The classical division based on surface stuff, like the falciform ligament.
The classical division, yeah.
But it turns out that map is, well, almost useless for a surgeon.
Completely useless, because for a surgeon or an interventional radiologist, anatomy follows the blood supply. It's all about the plumbing.
So the real map is functional, not just what it looks like from the outside.
Exactly. The functional division is what matters. It splits the liver into a right and left hem liver, right along the middle hepatic vein. And that allows you to subdivide it even further into 8 distinct segments.
And each of those 8 segments has its own plumbing, like you said, its own blood supply, its own biliary drainage.
Precisely, which means a surgeon can perform a segmentectomy, take out just one segment with a tumor, and the rest of the liver just keeps on working. It's incredibly precise.
Okay, so that's the macro view. Let's zoom in now from the segment to the actual working unit.
Right. And here's another key distinction. Historically, people talked about the hexagonal lobule.
Centered on the central vein, yeah.
But the unit that actually reflects how the blood flows and how metabolism is zoned is the hepatic acinus. That's the real functional unit.
And that focus on blood flow leads us straight to one of the liver's most unique features: its dual perfusion.
It's truly one of a kind. The liver gets blood from 2 sources at once. The bulk of it, somewhere between 50 and 90%, is nutrient-rich blood coming straight from the gut.
With the portal vein.
Through the portal vein. So it's full of everything you just ate, but it's relatively deoxygenated. The rest is fresh, oxygenated blood from the hepatic artery.
And that high proportion of venous inflow that has consequences later on.
Huge consequences. It means the liver is a low-pressure system, which is part of why portal hypertension becomes such a massive problem when things go wrong.
Okay, so this whole setup, this dual blood supply, creates the perfect scenario for our next big anchor: zonal vulnerability. Let's call the anchor oxygen zoning.
Perfect. Because the differences between the zones all come down to one thing: a gradient. Blood comes in at zone 1 and flows out past zone 3. So what the cells see changes along that path.
Walk us through it. Zone 1.
Zone 1, or the periportal zone. These hepatocytes are the first responders. They get the highest concentration of everything: oxygen, nutrients, and importantly, any toxins you've just absorbed.
So they're specialized jobs that need a lot of oxygen.
Exactly. Things like gluconeogenesis, making new glucose, and forming bile salts. They're also the first to get hit by toxins that are directly damaging without needing to be metabolized first.
Then you get to the other end of the line, zone 3.
Right, the pericentral zone, right up against the central vein. These cells are living in a relatively hypoxic environment. They get the leftovers.
So their jobs are different.
Completely different. They specialize in things that need less oxygen or in detoxification. So you see things like monooxygenation, glycolysis, lipolysis, and glucuronidation happening here.
So connecting this to pathology, if a patient has central lobular necrosis, damage specifically around that central vein, what should immediately pop into your head?
Ischemia or shock, 100%. Because they're the furthest from the oxygen supply, the zone 3 cells are the first to die when blood pressure plummets. It's why shock liver has that classic histological pattern.
That is such a critical connection. Location equals mechanism. Okay, Let's move from the zones to the actual microenvironment, the sinusoids and the space of Dissy.
Yeah, so the liver sinusoids are, they're not like normal capillaries at all. They're super leaky.
They don't have a basement membrane.
No basement membrane, and they're full of these little holes, fenestrae, that are about 0.1 micrometers across. This whole structure is designed to let plasma and all the molecules in it just pour out into the space of Dis.
Which is that little gap between the blood vessel and the hepatocyte itself.
Right. It's where all the exchange happens.
And who are the key residents living in this space?
Well, the heavy hitters are the Kupffer cells. These are the liver's resident macrophages. And the sheer number is just mind-boggling. The source material says they make up 80% of the body's entire phagocytic capacity.
80%? That's incredible.
It is. Their job is to be the bouncers, the cleaners. They gobble up bacteria and endotoxins leaking from the gut, clear out old blood cells. They're the essential filter.
And then there's the other cell, the one that really determines the liver's fate in chronic disease, the stellate cell.
Ah, yes. Let's use the anchor from the source. The sleeping dragon.
I like that. So what does this sleeping dragon do?
Normally not much. It just sits quietly in the space of Dissy, storing vitamin A. It's dormant, benign.
But it can be woken up.
It can be woken up. When the liver gets injured from alcohol, a virus, metabolic stress, whatever, the stellate cells get a powerful signal to transform. They switch from being quiet storage cells into hyperactive myofibroblasts.
What's the alarm clock? What wakes the dragon?
It's a cytokine storm. Injured liver cells, activated Kupffer cells, even platelets. They all start screaming for help by releasing these profibrotic mediators. The king of them all is TGF-beta1.
And once they're awake, what do?
They start spewing out collagen. They become the primary source of the dense, rigid scar tissue that replaces the healthy liver. This is the absolute key process of hepatic fibrosis.
And there's a really high-yield detail here about how they make things even worse.
Oh, absolutely. The activated stellate cells actually sustain their own activation. They create these autocrine loops with TGF-beta1, so the scarring process keeps going.
And they affect blood flow directly.
Directly. They produce a potent vasoconstrictor called endothelin-1, or ET1. This ET1 literally squeezes the scarred liver, which increases the pressure inside the intrahepatic resistance.
And that's the direct mechanical cause of portal hypertension.
That's the link. The cell biology of fibrosis directly causes the massive clinical complication of portal hypertension.
Okay, that's a perfect transition. From structure to output, let's talk about the liver's core functions, our anchor, the factory output.
Right. Synthesis is probably its most critical job. And we're mostly talking about proteins. The liver makes a huge amount of albumin, something like 8 to 14 grams every single day.
And albumin does two main things.
Two main things. It maintains oncotic pressure, so it keeps fluid inside the blood vessels. And it's like a taxi service, carrying around everything from bilirubin and hormones to drugs and calcium.
And the other major product?
The coagulation factors, specifically factors 2, 7-IX, and X, the vitamin K-dependent ones.
This brings us to probably the single most important lab test for acute liver function. Let's anchor this as the short life PT. So why is the prothrombin time, or INR, our best, quickest measure of an acute drop in liver function?
It all comes down to half-life. The half-lives of those coagulation factors are incredibly short. Factor 7, for instance, has a half-life of only about 5 hours.
So if the factory suddenly shuts down...
If the factory shuts down, say, from a huge paracetamol overdose, the levels of these factors in the blood just plummet within hours. So the PT, which measures how well they work, becomes a rapidly responsive measure of synthetic capacity.
And you have to contrast that with albumin.
Oh, absolutely. Albumin has a half-life of about 20 days. You could be in profound, life-threatening acute liver failure, and your albumin could be totally normal for weeks. It's a useless test for acute failure.
Which makes the PT a huge prognostic marker in that setting.
A powerhouse. In acute liver failure, a skyrocketing INR is a terrible, terrible sign.
Okay, now let's add the crucial clinical caveat. This is a classic trap for students. When you see a patient with chronic cirrhosis and a high INR, does that mean they're about to bleed to death?
Not necessarily. And this is where the idea of balanced coagulopathy comes in.
Explain that.
So, yes, the failing liver is making fewer procoagulant factors, which is why the INR is high. But it's also making fewer anticoagulant factors, like protein C and protein S.
So both sides of the scale are being lowered at the same time.
Exactly. The two defects can actually balance each other out, creating a new fragile equilibrium. Sometimes these patients are even prothrombotic, so you don't just give them blood products to correct the number unless they're actively majorly bleeding.
That is a massive clinical pearl. Okay, let's finish this section with the liver's waste disposal system, bilirubin metabolism. The anchor here is the excretion assembly line.
Right. The assembly line starts when old red blood cells are broken down and the heme is converted into unconjugated bilirubin, or UB.
And the stuff is lipid-soluble, not water-soluble.
Correct. Which means it can't travel freely in the blood. It has to be tightly bound to albumin. And because it's bound and not water-soluble, it can't be filtered by the kidneys.
So what happens when it gets to the liver?
The hepatocyte grabs the UB and uses an enzyme called UDP glucuronal transferase to stick glucuronic acid onto it. That's conjugation.
Which makes it water-soluble.
Makes it water-soluble. Now it's conjugated bilirubin, or CB, and the liver can actively pump it out into the bile.
And from the bile, it goes into the gut, which is where stool gets its color.
Exactly. Bacteria in the colon metabolize that CB into stercobilinogen and then stercobilin, and that's what makes stool brown. If you have a complete blockage of the bile duct, the stool turns pale, like clay.
We've built the whole blueprint, from the city map down to the assembly line. I think it's time to test that knowledge. Okay, here's our first check-in question. This is for you, listening. If a patient presents with sudden, severe liver damage, let's say from an acute drug overdose, what single laboratory test best reflects the liver's current synthetic capacity failure? And, more importantly, why is this test preferred over checking the serum albumin level? If you're not sure, just rewind and review the last few minutes on the Short Life PT.
Pause for 5 seconds. Okay, the anchor, is the prothrombin time, PT, or INR. It's all because of the incredibly short half-life of those clotting factors, some as short as 5 hours. Albumin, with its 20-day half-life, is completely useless for assessing acute failure.
All right, time to connect the dots. We've got the blueprint. Now let's see how its failure manifests at the bedside. This is about decoding the clinical clues.
This section is really all about pattern recognition. The physical signs of liver disease are often dramatic, but they usually signal that the disease is chronic and advanced. We're talking about cirrhosis, or significant portal hypertension. Our anchor for this is the head-to-toe checklist.
Okay, let's start at the top. The classic signs related to hormones.
Yeah, we're mostly looking for signs of excess estrogen, because the failing liver can't metabolize it properly. So you see things like palmar erythema, that's a redding of the palms, and of course, the classic spider naivety.
Describe a spider nevus for us. What's the key feature?
The key is that it's an arterial lesion. It's a tiny central arteriole with little capillaries radiating out like a spider's legs. Because it's arterial, if you press on the center, it will blanch, and then when you let go, it refills dramatically from the center outwards.
Now, I see these on healthy people sometimes. How many do you need for it to be significant?
That's the crucial clinical point. 1 or 2, especially during pregnancy, can be totally normal. But finding 5 or more, particularly in the distribution of the superior vena cava, so the face, neck, upper chest, and hands, that is highly suggestive of chronic liver disease.
And in men, there are other hormonal signs.
Right. Gynecomastia, which is breast tissue enlargement, loss of body hair, and sometimes testicular atrophy, all driven by that estrogen imbalance.
Then we have the signs that point directly to decompensation.
The big 3, jaundice, obviously, ascites, which is the fluid accumulation in the abdomen, and the flapping tremor, or asterixis.
And that's not a true tremor, is it?
No, it's not. It's a brief, sudden loss of muscle tone. You see it when the patient holds their arms out and extends their wrists. It's a very strong sign of the metabolic disturbance of hepatic encephalopathy.
And what about clues that point to a specific cause, the etiology-specific signs?
Use your diagnostic shortcuts. Dupuytren's contracture, that thickening in the palm of the hand, is famously associated with alcohol.
Although not specific for liver disease caused by alcohol.
Not specific, but a strong association. On the other hand, if you see xanthelasma, those yellow cholesterol deposits around the eyes, or lots of scratch marks, you should be thinking about a cholestatic disease like PBC, where the itching is intense.
And clubbing.
Clubbing of the fingers, especially with low oxygen levels, points towards hepatopulmonary syndrome.
Okay, now let's talk about actually examining the liver itself. Hepatomegaly. The textbook is really specific about the technique.
Yeah, you can't just jam your fingers under the ribs. You have to start way down in the right iliac fossa.
Why so far away?
Because if the liver is massive, you'll miss the edge otherwise. So you start low, and with each breath the patient takes, you press gently and move your hand up about 2 centimeters, feeling for that edge to come down and meet your fingers.
And you're not just feeling for size, but texture.
Texture is key. Is it smooth? That might suggest fatty liver or heart failure. Or is it irregular and firm? That's really suggestive of cirrhosis or a tumor.
Okay, from the bedside to the labs, our anchor here, the liver's report card. Let's start with the workhorses, AST and ALT.
These are your aminotransferases. They tell you that hepatocytes are being damaged and are leaking their contents. ALT is generally considered a bit more specific to the liver.
The most important clinical rule here is about the ratio between them. Normally, the Gestalt ratio is less than 1, but there's a huge exception we need to anchor, the alcoholic ratio.
This is a classic high-yield rule. The ratio flips, and the AST becomes much higher than the ALT ratio greater than 1.5, and often over 2 in 2 main situations.
What are they?
Number 1 is alcohol-related liver disease, especially acute alcoholic hepatitis. The mechanism is that alcohol damages the mitochondria, which releases a ton of mitochondrial AST.
And the second situation?
Advanced fibrosis or cirrhosis from any cause. Once the liver is really scarred down, the ratio just tends to flip. So if you see that reversed ratio, you have to think either alcohol or advanced disease.
Good. Now for the cholestatic markers, ALP and GGT.
Right. When you see a high alkaline phosphatase, ALP, you think about problems with the bile ducts cholestasis. But ALP isn't specific. It can come from bone, the placenta.
So you need a confirmatory test.
You need GGT, gamma-glutamyl transferase. GGT is very specific to the hepatobiliary system. So if both ALP and GGT are high, you can be confident the problem is in the liver or bile ducts.
Is there a catch with GGT?
There is. GGT can be elevated all by itself by certain enzyme-inducing drugs. The big one is ethanol, even without liver disease. Also drugs like phenytoin.
Okay, let's circle back to bilirubin. We can anchor this with pre versus post-hepatic jaundice.
You have to measure both the unconjugated and conjugated fractions. In pre-hepatic jaundice, like from massive hemolysis or Gilbert syndrome, the problem is before the liver. The liver's conjugation machinery gets overwhelmed.
So you get a rise in unconjugated bilirubin, but the other liver enzymes are normal.
Exactly. And because unconjugated bilirubin isn't water-soluble, it doesn't get into the urine, so the urine color is normal.
And post-hepatic.
Post-hepatic is a plumbing problem. An obstruction like a gallstone or a tumor. The liver is conjugating bilirubin just fine, but it can't get out. So you get a huge rise in conjugated bilirubin,
Which is water-soluble.
so it spills into the urine, making it very dark. And since no bilirubin is getting to the gut, the stools are pale.
This obstruction leads us to a famous clinical law. What's the finding that makes you worry about cancer?
It's Courvoisier's law. The finding is the combination of jaundice plus a palpable non-tender gallbladder.
Why does that suggest malignancy?
The thinking is that if the blockage were from chronic gallstones, the gallbladder would be scarred and shrunken from all the inflammation, so you wouldn't be able to feel it. But a tumor causes more rapid obstruction, so the gallbladder just passively dilates and becomes palpable.
Okay, so fibrosis stage is the key to prognosis. Let's talk about non-invasive fibrosis assessment.
Yeah, thankfully we've moved on from just sticking needles in everyone's liver. The non-invasive tools are critical, especially with the epidemic of fatty liver disease.
So what are the quick, simple scoring systems?
Things like the FIB-4 score or the NAFLD fibrosis score. You can calculate them from basic labs age, AST, ALT, platelet count.
And what's their main strength?
Their main strength is their high negative predictive value. A low score is really, really good at ruling out advanced fibrosis. It lets you reassure a huge number of patients without needing more invasive tests.
But if the score is high or intermediate?
Then you move on to measuring stiffness. The most common tool is transient elastography, or FibroScan. It basically sends a little vibration through the liver, and the faster it travels, the stiffer and more fibrotic the liver is.
What are its limitations?
It could be falsely elevated by simple inflammation or in patients with obesity. That's where magnetic resonance elastography, MRE, is more accurate, but it's also more expensive and less available.
This gives us a really complete diagnostic toolkit. Time for one more check-in on this section. Okay, here's our second check-in question. This one requires putting a few things together. A non-alcoholic patient has an AST to ALT ratio of 1.5. Their transaminases are a bit elevated, and their platelet count is low. They have thrombocytopenia. What two key histological findings are strongly suggested by that combination? Think about the 2 reasons the ratio reverses and what low platelets mean in liver disease. Pause and rewind if you need to.
Pause for 5 seconds. Okay, so the ratio reversal, AST over ALT greater than 1 in a non-alcoholic, strongly suggests advanced fibrosis or cirrhosis. And the thrombocytopenia, the low platelets, is a classic sign of portal hypertension, causing an enlarged spleen that just sequesters all the platelets. So together, this picture screams advanced, complicated liver disease.
All right, we are moving into the critical care side of things now. What happens when the liver's capacity just falls off a cliff? Let's start with acute liver failure, or ALF.
ALF is a clinical definition. It's severe, sudden liver damage that leads to two key things: a major coagulopathy and critically cerebral disturbance, so encephalopathy, in someone who did not have pre-existing liver disease.
And the causes vary a lot by location.
Tremendously. Worldwide, viral hepatitis is a big cause. But in places like the UK, paracetamol toxicity is the overwhelming culprit, accounting for 70 to 80% of drug-induced cases.
What's the one clinical sign that really defines ALF and dictates its management?
It's hepatic encephalopathy. And the early signs can be really subtle. It's just a little reduced attention span. Maybe their sleep-wake cycle is flipped.
But it progresses rapidly.
Very rapidly. It goes from that to confusion, drowsiness, and then full-blown coma. And the thing that can kill you in ALF, which is different from chronic disease, is cerebral edema. The brain actually swells.
We anchored the PTINR earlier. Let's just hammer home why it is so important here.
The PTINR is, without a doubt, the test of greatest prognostic value in ALF. You have to check it at least twice a day. The faster it's rising, the worse the prognosis.
And that leads to a really important management point.
Yes. You must avoid giving fresh frozen plasma, FFP, unless the patient is actively massively bleeding. If you give FFP, you'll temporarily fix the number, but you've just blinded yourself to your single most important prognostic marker.
So how do doctors decide that a patient is not going to make it without a transplant?
We use very strict validated criteria. The most famous are the King's College criteria. This is our anchor for who needs a transplant.
And what do they measure?
They identify patients with a mortality risk over 90% without a transplant. For example, in a paracetamol overdose, if the arterial pH is less than 7.25 after 24 hours, or if the PT is over 100 seconds, plus they have high creatinine and advanced encephalopathy, they need a new liver, fast.
Okay, let's shift from acute failure to the most common sign of chronic failure, ascites. This takes us to the splanchnic vasodilatation cascade.
This cascade is the absolute core mechanism of decompensation. It starts with portal hypertension. That high pressure in the portal system makes the blood vessels in the gut, the splanchnic circulation release, a ton of vasodilators, mainly nitric oxide.
So all the gut blood vessels just open up.
They open wide up.
Yeah.
And this causes a massive drop in the effective systemic blood pressure.
So the body thinks it's dehydrated or bleeding even though it's not.
Precisely. It senses this relative hypovolemia and freaks out. It activates the renin-angiotensin-aldosterone system and the sympathetic nervous system, which makes the kidneys hold on to every last drop of salt and water.
And that retained fluid, plus the high pressure in the portal vein, just leaks out into the abdomen.
That's ascites.
Now, to figure out why someone has ascites, you have to sample the fluid and calculate the SAG. What is that?
The SAG is the serum ascites albumin gradient. You just subtract the albumin level in the ascites fluid from the albumin level in the blood.
And the number tells you the cause.
It's incredibly powerful. If the SAG is high, greater than 11 GL, it means the cause is portal hypertension. The fluid is a low-protein filtrate. If the SAG is low, less than 11, it means something else is going on, something that leaks protein into the fluid, like cancer or TB.
That one calculation is a huge fork in the diagnostic road. Now let's talk about when that fluid gets infected. Spontaneous bacterial peritonitis, SBP.
SBP is a highly lethal infection of the acidic fluid, without an obvious source like a perforated bowel. It can be very subtle, maybe just a low-grade fever or some worsening confusion. You have to have a high index of suspicion.
How do you make the diagnosis? What does PMN mean?
The diagnosis is made by looking at the acidic fluid. If the polymorphonuclear leukocyte count, that's the PMN or neutrophil count, is greater than 250 cells per microliter, you've made the diagnosis.
And management has to be immediate.
Immediate and aggressive. You start broad-spectrum antibiotics like cefotaximine right away. Don't wait for the cultures. And, critically, you also give intravenous albumin.
Why the albumin?
It's been shown to significantly reduce mortality and prevent the development of kidney failure in the setting of SBP. It's standard of care.
And that kidney failure has a name. Hepatrenal syndrome, or HRS-AKI.
Right. Hepatrenal syndrome, acute kidney injury. This is a functional kidney failure. The kidneys themselves are perfectly healthy, but they shut down because of the crazy hemodynamics.
It goes back to that splanchnic vasodilatation again.
It all does. The body is trying so hard to compensate for the low systemic pressure that it clamps down on the renal arteries. It sacrifices the kidneys to try to maintain blood pressure.
And the diagnostic criteria have changed recently to help us pick it up sooner.
Correct. We don't wait for creatinine to hit a specific high number anymore. We diagnose it based on a significant change from the patient's baseline, which lets us intervene much earlier.
And treatment involves vasoconstrictors.
Yes, you stop any offending drugs, give albumin for volume, and then use powerful vasoconstrictors like terlipressin to try and reverse that systemic vasodilatation and get the kidneys working again.
Okay, this section was full of critical information. Let's do a quick check-in. Check-in question, decompensated disease. A patient with cirrhosis and ascites comes in with a fever. You do a paracentesis, and the PMN count is 300. What is the immediate life-saving management that you must start before the culture results even come back? This is a can't-miss diagnosis. If you're hesitating, rewind to section 3.3.
Pause for 5 seconds. The answer is you must immediately start broad-spectrum antibiotics and give intravenous albumin. Any delay dramatically increases mortality.
All right, let's move into viral warfare in the liver. This is a huge topic, but we'll focus on the high-yield points, starting with the DNA virus, hepatitis B.
Yep, HPV. Because it's a DNA virus, it can integrate into the host genome, which has long-term implications. But clinically, the most important thing to know is that the risk of it becoming chronic depends almost entirely on when you get infected.
You're talking about vertical transmission.
Vertical transmission. From an infected mother to her baby. That route carries a massive 90 to 95% risk of the baby developing chronic infection.
Huh.
Their immune system is just too immature to clear it.
And it's incredibly infectious.
About 10 times more infectious than HCV.
Okay, let's build our anchor for this. The serology master grid. There are 3 core markers. Let's go through them.
Number 1, HBsAg, the surface antigen. If this is positive, it means you have active infection. Could be acute, could be chronic.
Number 2,
Anti-HBs, the antibody to the surface antigen. If this is positive, it means you're immune. This is the one you get from vaccination or after you've cleared a natural infection.
and number 3 is a little trickier. Anti-HBC.
Right, the antibody to the core antigen. The core antigen itself isn't in the blood, so we measure the antibody to it, and this is where we have to distinguish between IgM and IgG.
What's the difference?
IgM anti-HBC is the acute response. If it's positive, you have an acute infection. IgG anti-HBC sticks around for life, so it means you have a chronic infection or you've had a past resolved infection.
Okay, let's run through the 3 most common scenarios using that grid. First, someone who is immune because they got the vaccine.
Okay, vaccinated.
Yeah.
So they're protected. That means they must be anti-HBs positive. But because the vaccine only has the surface antigen, they will be anti-HBC negative.
Scenario 2, someone with a brand new acute infection.
Acute infection. So the virus is active, meaning they are HBsAg positive.
Mhm.
And it's a new infection, so they'll be IgM anti-HBC positive.
And the final common scenario, someone who had it years ago and cleared it naturally.
Okay, so it's resolved. No active virus, so HBsAg is negative. They are immune now, so anti-HBs is a positive. And because they were naturally exposed, they will also have a positive IgG anti-HBC.
That grid makes it so much clearer. What about treatment for chronic Hep B?
The goal isn't usually cure, it's long-term suppression. We want to stop the virus from replicating to prevent from causing cirrhosis or liver cancer.
And the drugs we use?
The first-line drugs are incredibly potent and have a high barrier to resistance. They are entecavir and tenofovir.
And there's a critical safety warning if the patient might also have HIV.
A huge one. Both of those drugs also have activity against HIV.
Right.
So if you give one of them as monotherapy to someone with undiagnosed HIV, you could breed HIV drug resistance, which is a disaster. You must screen for HIV first.
Okay, on to hepatitis C. The cure revolution. This is an RNA virus, and the story here has changed completely in the last decade.
HCV is the definition of a silent killer. About 70% of people who get it develop chronic infection, and they can be totally asymptomatic for decades until they present with full-blown cirrhosis.
The treatment used to be awful.
Terrible. Interferon-based therapy had brutal side effects and low cure rates. Now it's a completely different world. The anchor is DAA classes, which stands for direct-acting antivirals.
What's so special about them?
They are oral pills that directly target specific viral proteins. These combinations have cure rates, what we call a sustained virological response of nearly 100% in just 8 to 12 weeks. It's one of the biggest medical miracles of our time.
What are the targets?
They're named after the viral protein they inhibit. There are NS34A protease inhibitors, NS5B polymerase inhibitors, and NS5A replication complex inhibitors. You usually combine two different classes to get those sky-high cure rates.
It's an incredible story. Okay, let's quickly cover the last two common viruses, A and E. The anchor is the fecal oral focus.
Right. Hepatitis A is an RNA virus spread by contaminated food and water. The single most important thing to remember is it does not cause chronic infection. You get sick, you recover, and you have lifelong immunity. There's also a very effective vaccine.
Hepatitis E is a bit more complicated.
A lot more complicated. Hepatitis E is now the most common cause of acute viral hepatitis in the world, and it has two distinct transmission patterns.
What are they?
In developing countries, it causes big waterborne outbreaks. But in developed countries, it's mainly zoonotic, meaning it comes from animals. It's usually spread through undercooked meat, especially pork.
And there are two very specific high-risk groups for HEV.
Two groups you must know. First, pregnant women. If they get infected with certain genotypes of HEV, they have a very high mortality rate, up to 20%.
But in the second group?
Immunocompromised patients. Unlike Hep A, hepatitis E can cause a chronic infection in people with weakened immune systems, and it can progress rapidly to cirrhosis.
This is all essential information. Let's do our viral check-in question. Viral hepatitis. A baby is born to a mother who is HBsAg positive. What is the recommended immediate prophylactic strategy for the newborn? And why is this specific exposure so high risk for leading to chronic infection? You need to remember both parts of the treatment.
Pause for 5 seconds.
Yeah.
The newborn needs immediate active passive immunization. That means giving the hepatitis B vaccine for active immunity and at the same time giving hepatitis B immunoglobulin, HBI, for passive immunity. The reason the risk is so high, 90 to 95%, is because the neonatal immune system is immature and often develops tolerance to the virus, failing to clear it.
Okay, we are in the home stretch. Let's move on to the chronic diseases that are really dominating liver colics today. Alcohol-related liver disease and NAFLD.
Right, the two biggest drivers of cirrhosis. The way alcohol damages the liver is complex. First, its breakdown product, acetaldehyde, is directly toxic. Second, the process of metabolizing ethanol completely messes up the cell's redox state, the NADH-NAD+ ratio.
And that altered ratio promotes fat synthesis.
Promotes fat synthesis and stops fat breakdown, which leads directly to fatty liver or steatosis.
And the gut is a major player here, too.
A huge player. Alcohol damages the gut barrier, making it leaky. This allows bacterial toxins to pour into the portal vein and travel straight to the liver, where they trigger a massive inflammatory response from the Kupffer cells. That's what drives the inflammation in alcoholic hepatitis.
And clinically, we circle back to our lab anchor. The ASTALT ratio 1.5, 2.0 is the classic hallmark of alcoholic hepatitis.
It is. Now, for management, there is one thing that is more important than anything else.
Abstinence.
Complete and sustained cessation of alcohol. It has the biggest impact on survival, period. For very severe alcoholic hepatitis, we also use aggressive nutritional support and sometimes corticosteroids like prednisolone. But the benefit of steroids is borderline, and they increase infection risk.
And how does this compare to AFLDM?
AFLD is the liver's manifestation of the metabolic syndrome. It's all driven by insulin resistance.
So you have too much fat flooding the liver.
Exactly. And when that fat just sits there, it's called NAFLD. When it starts to cause inflammation and cell death, it becomes NASH, non-alcoholic steatohepatitis. And it's only NASH that really drives fibrosis and cirrhosis.
And the key to treatment here isn't a drug.
Not yet. It's lifestyle change. A sustained 7 to 10% loss of body weight has been shown to cause significant improvement in the liver histology, sometimes even reversing fibrosis.
Okay, let's shift to the autoimmune diseases. The anchor here is immune system confusion.
Let's start with autoimmune hepatitis, AIH. This typically shows up with a hepatitic pattern, really high ALT and AST, often in younger women.
How do you diagnose it?
You need to find the right autoantibodies. For the most common type, type 1, you're looking for ANA or ASMA. And crucially, you also find a very high level of IgG.
And treatment is critical.
It's life-saving. You hit it hard with immunosuppression high-dose steroids to get it under control, then a long-term maintenance drug like azathioprine.
Now, for the two big cholestatic diseases where the problem is in the bile ducts, first, primary biliary cholangitis, PBC.
PBC is almost exclusively a disease of middle-aged women. The absolute diagnostic hallmark is the presence of antimitochondrial antibodies, AMA. You'll often see a high IgM level too.
And what's being attacked?
The immune system is destroying the small and medium-sized bile ducts inside the liver. The main treatment is a drug called ursodeoxycholic acid, or UDCA.
And we have to contrast that with primary sclerosing cholangitis, PSC.
PSC is very different. It has a very strong association with ulcerative colitis. And here, the damage is to the large bile ducts both inside and outside the liver.
How do you diagnose PSC?
You can't use a blood test. You need imaging. And MRCP will show the classic finding: multiple irregular strictures and beading of the bile ducts. It looks like a string of beads.
And PSC carries a very sinister risk.
It does. A very high risk of developing bile duct cancer, cholangiocarcinoma. It's the leading cause of death in these patients, so they need constant surveillance.
Okay, last category. The inherited storage disorders. Anchor. The overload.
The two big ones are iron and copper overload. First, hereditary hemochromatosis. This is iron overload, caused by a gene mutation that leads to uncontrolled iron absorption from the gut.
And the classic presentation.
The classic triad is skin pigmentation, a bronze-color diabetes, and arthritis.
And the treatment is surprisingly simple.
It is. Therapeutic venesection. You just regularly take blood off, which forces the body to use up its excess iron stores to make new red blood cells. If you catch it before cirrhosis, the prognosis is excellent.
And the other one is Wilson's disease.
Wilson's is copper overload, from a different genetic defect that stops you from excreting copper into the bile. It can present in many ways, from acute liver failure to a progressive neurological disease.
What's the key clinical sign to look for?
The key sign is Kaiser-Fleischer rings. It's a greenish-brown copper deposit in the cornea. You often need a slit lamp exam to see it properly. Treatment is lifelong therapy with chelating agents to remove the copper.
Okay, one final check-in to tie this all together. Check-in question. Disease differentiation. A young woman comes in with acute hepatitis, so a high ALT. You suspect an autoimmune cause. What two key blood test results would point you towards autoimmune hepatitis, type 1, and away from the cholestatic disease, PBC? Think about the specific antibodies and immunoglobulins.
Pause for 5 seconds. For AIH, you would be looking for a high ANA or ASMA combined with a generally elevated IgG level. PBC, on the other hand, is defined by the presence of AMA and usually has a high IgM, not IgG, and a cholestatic picture.
We have covered a huge amount of ground, an amazing deep dive into hepatology. Before we wrap up, let's just quickly review those final durable anchors.
Okay, let's do it.
The functional unit is the acinus. Zone 3 is the hypoxic zone, vulnerable to shock liver.
The PTIRR is your go-to test for acute synthetic function. Don't forget to contrast that with a MELD score, which we use to predict mortality in chronic disease.
And a STOLT ratio over 2 screams alcohol or advanced cirrhosis.
AMA means PBC. That's a small duct disease in women.
And beating on MRCP means PSC, which is linked to UC and a high cancer risk.
That's a great summary. I just want to circle back to one final, really practical clinical point about our patients with cirrhosis. It's about nutrition.
Sarcopenia and protein. This is something that has confused people for years.
It has. Malnutrition and muscle-wasting sarcopenia are incredibly common in these patients and make every single complication worse. For decades, the dogma was that you had to restrict protein to prevent encephalopathy.
And that's wrong.
It's completely wrong. We now know that protein restriction is harmful. It makes the malnutrition worse, which worsens their overall prognosis.
So what's the recommendation now? Aggressive
nutrition. These patients need high-calorie and high-protein diets. We're talking about 35 kilocalories per kilogram per day and 1.2 to 1.5 grams of protein per kilogram. And giving them a late evening snack is really important to prevent them from breaking down their own muscle overnight.
That's a huge shift in practice and a vital take-home point.
Yeah.
All right, it's time for our final provocative thought for you to chew on. We've established that chronic liver disease from almost any cause increases the risk of hepatocellular carcinoma, or HCC. Now, given the absolute explosion in the prevalence of NFLD worldwide, and knowing that HCC screening is only cost-effective when the annual risk is above about 1.5%, should we start routinely screening all patients with NFLD for liver cancer, even before they have clear-cut established cirrhosis?
A fascinating and very real dilemma for the next generation of clinicians. Keep anchoring those core concepts, and thank you for diving deep with us.
We'll catch you next time.